Good morning, FLaNET Carcinoid community. Thank you so much for giving us your time today. My name is Dr. Mena Haider. I'm a medical oncologist at Moffitt Cancer Center in the NeuroEndocrine program. I'm joined by Tamia Tauba, who's the director of research for the NET program. And today we are highlighting our colleagues at Jupiter Medical Center. This is our second meeting. We are joined also by a special guest who is able to join us, Josh Mailman, and he is the true meaning of patient advocate and innovation. I'll be introducing each panelist as their time comes to speak, but we have a lot of expertise joining us today. And I also want to thank the Jenkins family for being the founding members of this community for us. Tamia, would you like to add anything?
No, I think you said it. We're looking forward to a good program today, and thank you for everybody willingness to adjust.
Yes. Now we'll hold questions, but we do have some time dedicated to questions. So you can send your questions to the chat or raise your hand when we open up for questions, and we will welcome them at that point. So to begin, an introduction, although it doesn't serve him because it's short, but Mr. Mailman is an internationally recognized advocate for NET patients, as well as an advocate for integrative oncology, nuclear medicine, and molecular imaging. He's the chairman of the society. He's the inaugural chairman of the Society of Nuclear Medicine and Molecular Imaging, Patient Advocacy Advisory Board, a member of the Education and Research Foundation for Nuclear Medicine and Molecular Imaging Board, and is the president of NorCal Carcinet Community. On behalf of my colleagues, I think we can all agree that he's been a great source of feedback and guidance for us, even as providers in the NET community as well. Josh, I'll hand to you.
Good, and I'll take it. And I'm going to share my screen here. We're 20 years into the pandemic, or at least 3 years, so I should be able to do this pretty well. You guys can see my screen, right? All right, my screen's off to a little bit to the right, and my camera's in front of me, so if I look off to the side every once in a while, that's it. So this is kind of the conversation that was given to me to discuss, which is an interesting combination of topics, which goes from support groups to clinical trials to everything in between. And as many of you know, I was in Jupiter yesterday. I'm now back in Oakland, California, where my crew is here in Northern California. And actually that experience helped me put together this concept of how they actually interconnect and why it's important to talk about local patient support groups and how that goes farther into helping things like clinical trial websites and other things that we've done. So without much further ado, and some of this may be a little different because of the number of people, I won't. These are my disclosures. I'm wearing one of our running jackets. You saw us here before at the one of the pre-pandemic running festivals where we had 120 people out. This was this year's running festival, so you can see who supports us and who works with us. I can tell you, none of them have know anything about this presentation at the moment, so I really don't have any great disclosures. We did this yesterday. It was kind of fun, but there's not a ton of people here, so I'll take it that most people are patients here. We may do a little bit more of this, but if you have a moment and you want to do your active poll and take a screen there just to see who you are, but I'm going to assume we've got a bunch of patients here, which is great. But have your cell phone ready because we'll do something we did yesterday in Jupiter as well. A little bit about me, a little bit, but thank you for the kind introduction, a little bit about NorCal Carcinet and why community support groups really still have a place, even in this virtual world where we can do all of this and meet up with people from around the world. But what's different about thinking locally? A little bit about patient advocacy and how patients can make a difference. And I promise to get this done all before the top of the hour. How's that? That work? Yeah, seeing shaking heads. So, right, my background, I was blind pickup. We always start with a patient story. And yes, I've done a bunch of integrative oncology, nuclear medicine work. There's been articles written, but mostly at this point, I do a lot with the NCI, where I co-chair patient advocacy steering committee with helps about 75 different patient advocates learn how to approve and vote and give their voices to clinical trials that the NCI will fund. We are not that we're the gatekeepers, but we're one vote in NCI clinical trials that will go forward with across cooperative groups. And I'm a member of the ASCO Scientific Research Committee, where I'm one of 3 patient advocates on that committee. And I always kind of joke that the other 2 are breast cancer patient advocates. So to ASCO, anything outside of breast cancer is a rare disease. So I have good backgrounds of working with it, because I work with patients with rare diseases. And the more interesting thing, and Boris can't really respond to this, and since we're in a webinar, it's hard to do this, but I'm the sole patient right advocate for the Nuclear Regulatory Commission's advisory committee for the medical use of isotopes. So as it turns out, medical isotopes are regulated not by the FDA, but by the Department of Energy through the Nuclear Regulatory Commission. And I don't know that I'll put anyone on the spot today, but yesterday when I put people on the spot, I think Boris had the largest number that thought there was 1 million nuclear medicine procedures done a year in the United States. And the number is actually 24 million. And so I manage, or I represent patients for 20 to 26 million procedures that are done every year in the United States. So a little bit, we started this conversation, I think Dr. Strosberg or Jonathan certainly called me, and now I'm trying to remember how many years ago, to say we'd like to start something in Florida that represents our community. And so we've had talks over the years about this. I think one of the interesting things is these things don't happen overnight. In our case, in NorCal Carcinoid community, we started as a local group. It was started long before me, actually the year of my diagnosis in 2007, by a few members of the community who wanted to get together and discuss treatment options and understand how to support each other. And we had grown. We were part of the cancer support community. Back then it was the wellness community and also Gilda Center. But we were just a community group that brought in a little funds so we could support some speakers coming in to talk to us. The wellness community was our fiduciary agent, who found that they didn't want to be our fiduciary agent. They were fine housing us and us paying rent, but they weren't fine handling money for us anymore. So in 2011, matter of fact, on Valentine's Day of 2011, we incorporated, and as time switches, I was invited to join the community as a leadership in 2010, and by 2011, I became president of the new incorporation. And, one of the things that I emphasize is consistency. We meet the first Saturday of every odd month at the Cancer Support Community, and the first Wednesday of every month at UCSF, and we're working on doing that with Stanford as well. So we have this consistency that's allowed us to grow. And at this point, because of the pandemic, obviously we switched to doing virtual meetings as well. We actually do 2 a week for support that range from 5 participants or 10 participants to 25 participants. every Tuesday and Friday at 11 o'clock our time. Any of you who are hearing this or seeing this in the future, you're welcome to join us. We also host yoga for neuroendocrine tumor cancer. We have that virtually as well. We had 135 participants in last year's Oakland Running Festival. This is 2022 numbers. We had pretty much the same number in this year, and I'll show a picture of that later. We run our own message board, which has run about 15,000 messages a year. We work with, as was noted, the many organizations, Society of Nuclear Medicine. We'll work with anyone. But more importantly, I think, is what we can do as a local support group. We've grown over time, right? We have 150 plus donors who actually contribute. So that allows us to do things that are different and very communities focused and different than what a national body would do. We fund 4 to 8 healthcare professionals to go to different meetings. We sent 4 to NANETS last year in DC, and these are professionals who would normally be funded. So that way we can make sure that our local community, the people who take care of us, can learn more about this disease and be better and better serve us. We've also funded clinical trials that are local. There's a clinical trial, or not a clinical trial, but a survey, a long-range survey that UCSF has done, and we fund the maintenance for it, for instance. So that's the difference in what you can do locally. One of the reasons I love working with local groups as well is I learned some things, and I learned some things yesterday just being in Jupiter with another group, and we'll talk about that a little bit. In 2017, I started something called Speaking Up. It kind of fizzled out during the pandemic, but I actually traveled, and it was talking about communications. And I bring this up because one of the things I like doing about doing this little tour that I did, this brought me to 14 different support groups around the country. And one of the things I found is that each one of them has different issues, different challenges, and different successes. And for me, working with ASCO or working with the NCI or working in my capacity of the Nuclear Regulatory Commission, it's important for me to understand how these different things, this regional variability can happen, and trying to bring that flavor back to those I help represent. And this is where I went in 2019 and 2018. We were talking earlier before this webinar started about how it's beneficial to be flexible in your travel. I can tell you doing a 14-city tour in 2 years was something that required a great deal of flexibility, but it happened. And we've done that. And, one of the things that I talk about, if you want to, there's videos of many of these online already because it was a panel, but one of the things we'll talk about is a single overriding communication objective, that anytime you talk to your healthcare professional, that know what you want to achieve. You have about 30 seconds before you lose control of a conversation with your healthcare professional, and they will speak, and their overriding objective will come in, and they'll control the agenda of the meeting. So as patients, if to be successful, ask that, if you can record the conversation and know what that one thing or that 2 or 3 things are that you want to get taken care of, and that will make you feel complete by the end of this. I'm gonna skip the survey only for the matter of time, but if you want to It's up right now. I'll give us about a minute and see if anyone actually is willing to do that. All you need to do is point your phone at that QR code or fill that in, and I'll see if anyone is doing it. Although I don't see anyone up and running at the moment, so Jonathan's going to try. There you go. But, you know, I've asked the same 5 questions now in 16 different locations, and that is, you know, it's taught me, and I look back at it, and you think that these things would normalize and that you would find it, and again, each of these places may have only you know, 20 to 30 people in them, and maybe only 10 people will actually do the survey. But what you'll find, or what I find, was some normalcy until yesterday, of course, where I learned something completely new. And that's why you keep doing these things, because you learn something new. And so let's see if anyone's really, let's see, what are your biggest barriers in talking? Yeah, time. And for all of us, it's actually having yesterday's, I think the overriding one was time and fear, that people are fearful of talking to their doctors. And so we learn about these things. So let's see, we still have one person responding, but I'll go ahead, and this won't be obviously that huge of things, but so, you know, with only 2 participants, it's hard to get a big number here, but yes, this is, when certainly working in the NET community, I find that we do have kind of a bimodal distribution. You know, we're looking at, I actually don't know where most of the patients are, where our 3 or 4 people are, but we'll see this all over the place. This is one that, you know, that has changed a lot, not over time, but a lot of patients are fearful of asking for second opinions. But your doctors aren't fearful of actually having second opinions asked for, and they'll help guide you for that. So this is interesting. I only say this, again, small numbers here, but I will bring this up. This is, on the left is what is typical in the 14 ones that I did prior. It was almost like this all the time. And as you can see, usually was the second, but never over 25%. And yesterday it was 60%. And here we can just see on a notepad was, and I don't know if it's something about Floridians or something about the difference, but I never saw being, you know, in my head has always been greater than 50, and that's an interesting thing, and I congratulate you for it, because it's really important to do that. So that was a fun little survey, and thank you all of you who participated in doing that. That was great. I want to spend the last few minutes here both talking about magnifying your voice, not only at a local level, but what you can do as an advocate and or as a patient contributor, however you want to look at that, and a little bit about one of the tools that NeuroEndocrine Carcinoid funded last year and still working at rolling out. So this is a friend of mine, Deborah Collier, who has this view of, we hear the word patient advocate and we think of one thing, or we all have our preconceived notions of what that is. And really advocacy is all over the map. And I ran one of those word clouds at a conference that I was talking to last year called the Gordon Research Conference for Nuclear Medicine. And the word support comes through, but it is all over the map as about what people think advocacy is. And it can be anywhere from patients' right advocacy to an advocate following you around your health center, to what we do here in patient support, to research advocacy, to what I do with the Nuclear Regulatory Commission, which is regulatory or watchdog as well. And so there's just many flavors. And the NCI has, and why it's important to have advocacy and have research advocacy. Doctors look from the top, and we look up at what's going on. So we have a different view, and I also borrowed this slide from one of my co-chairs, but I like it because our perception is different. This is the NCI's definition of what advocacy does for research, just so you get an idea. And it's about collecting patient perspectives. But what I wanted to get to lastly is, with all of that, you can change the world. Defining where you want to be in this kind of continuum of patient advocacy or patient support or patient involvement. You can think locally. This is sponsors supporting your local medical community wherever you are, looking at your local patient organizations, because they're going the potential to fund things locally and to support those in a local community and learn about what can change locally is something that happens in the local environment. And, while I'm certainly sit on a board of a national group as well, I'm the treasurer of the NeuroEndocrine Tumor Foundation, it's harder to look locally and to know what's going on in your local community as much, and to give small grants to bring the entire group up to speed in the neuroendocrine tumor community. Think nationally, comment on policies that impact you. ASCO, for instance, asked for patient input on guidelines and other on guideline development and other things that happen. I will put out things in my advocacy newsletter, which you can sign up for. The URL is down there, where if I'm asked for public comment or see public comment that can be done, I will reach out to patient advocacy or patients in our group to say why this is important that you comment and make your voice heard. National organizations funding really help looking at funding research and keeping our medical professionals in funding or interested in neuroendocrine tumors and the research there as well, and young investigators. And lastly, think globally, which is besides the national organizations and global organizations, we have, patients can change how things work, either in participating in research as an advocacy on a research committee, and or by actually enrolling in clinical trials. And one of the things that we found was that we would tell people to go look at clinicaltrials.gov, and honestly, it's a challenge. It's a challenge because clinicaltrials.gov is kind of a messy place, and unless you know what you're doing, it's really hard to figure out exactly where you're going. Let me see if I can. And I'm assuming you can still see my screen, right? If I can get back to, there we go. I want to X that out, and yeah, you can still see that. Strangely enough, it isn't exactly where I wanted to be, but that's okay. I'll get there. And one of the things, and I know we're all in a Zoom world and it's hard to have real interaction in the Zoom world, but I've been fortunate not only once but twice to end up in breakout rooms and different parts of conversations in Zoom, meeting people I've never met before. And one of them turned into that, was on our slide on a PRRT grant where we received $5.1 million to study sequencing and quality of life for neuroendocrine tumors. A epidemiologist picked me out after hearing me talk and said, can we write a grant together? And randomly that worked. And this was another random conversation where I was talking to someone or in a Zoom breakout talking about the mess that is clinicaltrials.gov and how to use AI to filter through all the exclusion and inclusion criteria to have a what I'll just say is a moderated or an expert panel look to see what might be the best fitting clinical trial for you. Because, you know, at the end of the day, it's really important that you find a clinical trial that works, that is geared for you and your challenges. So I'm just going to quickly, we're in Florida. I'm in intermediate grade. The tumors has progressed. My symptoms are not well controlled. I've received treatment and I'm on a somatostatin analog. I've never had any of these other things. I'm over 18, which is why you have this question. And I'm pretty active. And with just a few clicks of an expert, there's one trial, and that may not be 100%, but it starts to have a conversation about what you specifically looked at. And this is a way to start a conversation with your physician and also look at something that is a little easier to work with, as far as then seeing, I'm going to, I'll take this particular one, and then see a little bit about where it is, what the treatment's offering, what the detailed description is, what the drugs are, and actually how to get in touch with this particular, or make an actual Excel file that I can share with my team and discuss if any of these make sense or why they don't. And with that, my promise was to do this at the top of the hour. And I'll just because I was there for all the fun rain that you guys recently had, this was this year's running festival. We, even though it turned out that it was pouring, as you can see, we ended up getting 90 people out to run and raise over $10,000 for NeuroEndocrine Carcinoid on this one very wet, the wettest day we've ever had doing this. And with that, I will turn it back to you. I will stick around for questions or just to hear, because I love to learn from everyone. With that, I will stop sharing. I think I can stop.
Thank you so much for sharing your experience. And I want to highlight that, you know, you've made yourself as much as possible to help patients and net providers. And this is an example of it. I know you made extra time for us today, so thank you so much.
No worries. Good to be here.
Before we switch gears to treatment, I think we should pause here and see if we have any questions that we can welcome to Josh or for Josh. And Tammy, I might need your help to see those.
Yeah, you guys can put questions in the Q&A or the chat. And if you raise your hand and you want to unmute, just do that and I'll unmute you.
And while you get comfortable with that, I think I can start with a question. So at the beginning, you hinted at some changes that happened with the pandemic and then using some of the things we've learned during that time, like connecting electronically and how you've made connections that maybe you would not have made without that learning. But what are some challenges that have continued or from that, pandemic time in creating groups or meetings, and how have you worked around them in terms of patient advocacy?
So, in terms of patient support groups for neuroendocrine tumors, I think what I'm seeing in our group, and again, our group's a pretty wide catchment areas, or pretty wide group as well, but we have a mix of people who want to meet back in person and some who are really challenged with that, and now making sure that every meeting has a hybrid component to it, and actually a hybrid component that has, high quality video where people can hear, and that we also maintain patient privacy across that is actually oddly driving up the cost of doing this, because it requires more resources and more skilled people, and it's still a work in progress. We had 2 meetings last year that were hybrid in towards the end of the year in cancer support community, but we couldn't get critical mass at our UCSF lunchtime meetings to make that happen, and they both slipped into virtual. So we're in this little start-stop range of trying to figure out, and we don't know if we never actually deviated from our meeting schedule. Every even though we added meetings, this virtual kind of check-in during the week that has become very popular, we never stopped our first Saturday at 1 to 3 meeting, and our first Wednesday on odd month always have a UCSF speaker. So nothing changed. The cadence of our drumbeat is still the same, but trying to figure out when that inflection point of switching and how we do that has been one of our ongoing challenges, and I don't have a perfect answer for that.
Thank you. Any other questions, Tim?
Not right now, but we will have time at the end if you guys want to mull over that, and then you can send them in the Q&A, and I'll flag them for Josh to respond to.
Yes.
Yeah. And listen, I love hearing about people's experiences, because that's what helps me actually represent you better at the various different places that I'm able to represent you. So I'll stick around and listen.
Thank you, and we'll share the links that you pointed to during your visit. We can now share Dr. Boris Naraev's discussion, and I'm happy to introduce him this morning. He is the program leader of Jupiter Medical Center's gastrointestinal, neuroendocrine, and rare cancers programs. He specializes in treating patients with cancers of the digestive system and neuroendocrine tumors of any location. Prior to joining JMC, he was the program lead of the neuroendocrine cancer program at the Banner MD Anderson Cancer Center in Phoenix, Arizona, and adjunct assistant professor at the Department of Gastrointestinal Medical Oncology at the University of Texas MD Anderson Cancer Center. He believes in compassionate, personalized care that is focused on his patients, their hopes, needs, and quality of life, and he's a wonderful colleague to us as well. So you're going to be discussing treatments targeting the somatostatin receptor, and if you want to take a moment also to introduce JMC, I welcome that as well.
Okay, thank you for introduction. Well, Jupiter Medical Center is a beautiful hospital, and we have beautiful cancer center here. So, and a lot of patients, and we have a great team here that takes care of obviously all the cancers, including gastrointestinal, and we have surprisingly high number of patients with neuroendocrine tumors as well. So, and it's a beautiful place, and I already mentioned. So, okay, so we'll talk today about somatostatin analogs and PRRT. Let me see how it works. Okay, we talk a lot about it usually, but I think from patient perspective, it would be probably a good idea to mention what somatostatin is, because we mentioned it a lot, but In fact, it's a reasonably small peptide, which is a combination of amino acids. It has 14 amino acids in it, and the function is inhibition of secretion of multiple hormones. So I will show you a long list of things that somatostatin does in the body, but I always remember probably the best explanation that Dr. Odericio, rest in peace, gave to us. He said that somatostatin is a universal switch off because it essentially downregulates many hormones. It's produced by paracrine cells in gastrointestinal tract. It inhibits endocrine secretion in the GI tract, as well. It is found in different locations in the nervous system, and it helps the nerve system exert control over many physiological functions in the body. So this is the list of hormones that somatostatin inhibits. So it's reasonably long. I obviously I will not spend much time going through the list, but it's good to remember this is a universal switch off. So, and this is what it does, as you can see, according to the substances that it inhibits. The effects are many. So in the liver, as you see, it decreases blood flow, inhibits bile duct secretion, inhibits gallbladder contraction. In the pancreas, it inhibits practically everything the pancreas does, and we see it in the clinic because chronic use of somatostatin analogs can cause issues with the pancreas, starting from blood sugar level controls and not ending but continuing to diarrhea when people cannot digest fats and it very much by somatostatin. So, and since it was reasonably small peptide, obviously the analogs were created by humans. So there are 3 analogs currently approved in the United States. It's octreotide and lanreotide, with which many patients in neuroendocrine tumors are familiar because these are the only 2 that are used in the United States for treatment of patients with neuroendocrine tumors. And pathology is approved, but not for cancer-related indications. So there are slow release formulations for octreotide and lanreotide, 1 injection per month. Usually it helps with patient compliance. It's reasonably easy to remember and reasonably easy to have this injection. Of course, when you don't look at the needle, especially when you talk about long-acting octreotide, it's a long needle. So, and there is an octreotide in the pill form. So it's not approved yet for use in people with neuroendocrine cancers, but the trial is ongoing. So, and as well, that there is a trial that is ongoing related to self-injected form of octreotide. If everything goes well, so it will be available to patients in the pen form, and it would be injected by the patients at home once every 2 weeks. But that's the Sorrento trial, I believe the name. But we are not there yet. We are not there yet, but lots of research. So what somatostatin analogs do to neuroendocrine tumors? Usually they slow the growth of neuroendocrine tumors. So mechanisms are different, direct and indirect. The direct mechanism is activation of somatostatin receptors, and I will talk about those receptors in a few minutes. They are present usually in great numbers on the neuroendocrine tumor cells. And when they are activated by somatostatin analogs, the cell cycle is arrested. And in some cases, apoptosis or autodeath of the cancer cells happen. And there is indirect mechanism when somatostatin analogs are binding with somatostatin receptors that are present on some blood vessels that are located in the tumor. And it indirectly inhibits tumor vessel development and secretion of growth factors. So in real life, we do not see that somatostatin analogs do shrink tumors, probably less than 2% chance. So, but usually they are very effective in slowing the growth of tumors. So somatostatin receptor is a key player in practically all things neuroendocrine. It is present on the surface of most low-grade neuroendocrine tumors. So, and it is what makes neuroendocrine cancers different, and that's what makes treatment of neuroendocrine cancers is unique from many other cancers. So it's present, as I said, on majority of low-grade neuroendocrine tumor cells. So there are monoclonal antibodies against the somatostatin receptor. There are five types at least. We mostly care about somatostatin receptor type 2. So you can use this monoclonal antibody and you can stain and you can see it. Here you see how the tumor cells are stained for somatostatin receptor type 2, and sometimes we use it in the clinic. Well, let's say tumor is removed and there is a question if tumor has somatostatin receptors and there is no way to do the PET scan because tumor is out. Sometimes you can stain it, and we ask our pathology colleagues and we receive those reports. So as well, you can see it. You can take picture of it. This is the somatostatin receptor-based PET scans, which, as many of you know, started with gallium-68 and now it's copper-64. So you can see tumor location. So the dotatate, which is a type of somatostatin analog, and it's labeled with gallium-68 or copper-64 isotope, and you can see it. You can see it. So let me see one more. So, and if you use the same dotatate, but instead of nice and gentle isotope like gallium-68, you attach lutetium-177, you can use the presence of this receptor for treatment of neuroendocrine cancers. And this is the concept of PRRT. And we will talk about it in a minute. So, and speaking of PRRT, John, I always have to show this classic diagram sorry, let me go back, that showed how well PRRT works, how well utilization of this receptor can help patients and doctors to control cancer. So, and somatostatin receptor is obviously of great help when you use somatostatin analogs. So octreotide and lanreotide, as I mentioned, the two drugs that are approved in the United States for use in patients with neuroendocrine cancer. So as I mentioned earlier, what they do, they decrease cell growth, they increase cell death, and they decrease the secretion of hormones. And they can be obviously used not only to control the growth, but as well in those biochemically active tumors, they could be used to control production of hormones and the symptoms related to those hormones. So they're very effective in controlling those symptoms. And depending on what symptoms are, from diarrhea to low blood sugars to high blood sugars, those symptoms in many patients could be well controlled for a long time. So tumor growth is controlled. I wish they could shrink, but it's probably less than 2% chance, as I mentioned, but in many cases, in many patients, it controls disease progression for many years. So, and disease progression is delayed. And very likely, and we see it in clinics every day, it increases overall survival. People live longer because disease is well controlled. And in the interest of time, let's move on to peptide receptor radionucleotherapy, PRRT. As I mentioned, majority of neuroendocrine tumors have very high number of somatostatin receptors on the surface compared to other tumors. The treatment, PRRT, targets those receptors. To put it simple, this is lock and key system. So you see this on the picture. So that there is somatostatin receptor type 2. There is octreotide peptide, which is key and lock. And there is a linker in form of DOTA. And you attach lutetium, which is the isotope that actually does the damage to DNA of the cancer cells. So this treatment and this concept was known in Europe for the last probably 30 years, and it was used widely. And until this treatment was approved in the United States, many patients used to go to Europe for this treatment. And objective response rate means when you do the scan and you see that that the treatment does something to the cancer, and cancer response to treatment is anywhere from 15 to 35%, depending on the publication and depending on the database. And it was shown to improve quality of life. People live longer, and disease stays stable longer with this treatment. So it works very much like Trojan horse. I like this picture. Dr. Kapdanerson kindly let me borrow it. He uses it all the time. You see the concept that there is a receptor. The somatostatin analogs labeled with lutetium-177 is attaching to the receptor. Subsequently, the receptor is what we call internalized. This cancer cells takes it inside. So then the degradation of the complex of the receptor and somatostatin analog and the isotope happens. And then radiation is released inside the cells. DNA of the cell is damaged, and the cell, in many cases, is dying. So this is the concept, that this is how it works. So the official, and this is actually how the lutetium-177, the brand name is Lutathera, that's how it looks in real life. This is a little bottle, which is very radioactive, obviously, because it has lutetium in it, and it comes in this container to make it safe. So the official indication is for treatment of somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors, and it includes foregut, midgut, and hindgut. And it's only indicated for treatment of adults. Of interest, as many of you know, the clinical trial, NATER-1, that led to the approval of this treatment in the United States, did not include patients with pancreatic neuroendocrine tumors. Only patients with tumors that originated in the small bowel were included. However, FDA did include pancreatic neuroendocrine tumors on the list of indications, which was surprising, but it was a great thing. I remember, and John, you probably remember as well, when we were doing the expanded access protocol, we did manage to treat quite a few patients with pancreatic neuroendocrine tumors on an individual basis. We had to ask for FDA approval, and it was effective. It was effective, so it was a good thing that FDA approved it not only for a small bowel origin, but as well for pancreatic neuroendocrine tumors. So how patients are selected for PRRT? Because patients are very much interested in who is eligible, who is not eligible, because there was much anticipation before PRRT was approved. And many people think that they still think that this is sort of a holy grail, which it is, but this is not for everyone. This is not for everyone. So usually patients for PRRT, good candidates for PRRT, are those who have either inoperable, and cannot be removed surgically, or metastatic, that again cannot be removed surgically, well-differentiated grade 1 or 2 neuroendocrine tumor. So well-differentiated, and Dr. Schrader will be talking about it later, it's essentially those tumors that look nice under the microscope, and grade 1 and 2, those are with Ki-67 index less than 20%. And I don't want to spend much time on Ki-67, but this is essentially percentage of cells that are actively dividing. The higher the number, the more aggressive the tumor is. So as well, we do consider patients with well-differentiated grade 3 neuroendocrine tumors. This is a rare entity that was just recently recognized, but as long as somatostatin receptor is expressed on the surface and the tumor is bright on the dotted PET scan, it's very likely the patient might be candidate for the treatment. As well, bone marrow resource should be sufficient, especially if we plan to treat the patient whose disease metastasized to the bones, because obviously there will be higher chance of bone marrow exposure to radiation. And if there is pre-existing issue with bone marrow resource, means the bone marrow cannot produce enough blood cells, treatment might be a problem with isotopes. Kidneys should be healthy. Obviously, that's why we're looking for creatinine clearance, more than 50 milliliters per minute. So patients should be in reasonably good shape with Karnofsky performance score more than 50%. And the expected survival should be more than 3 months because the treatment takes several months. It's usually 4 infusions, at least 8 weeks apart. And of course, patients should be in good shape, and the life expectancy should be long enough for this treatment. So in terms of efficacy, again, the classic slide. When it was published in 2017, progression-free survival was not reached. The expectation was, I believe, 28.4 months, but it was obvious even then that the treatment is effective. You can see here, this is the dark line is a control group, and the green line is the group that was treated with lutetium-177. And you can see that progression-free survival was significantly higher in the treatment group. Side effects is always of a concern with this treatment. We used to think that this is potentially very toxic for kidneys, which makes sense, but subsequently with the use of amino acids that have protective action, they exert protective action in the kidneys, turns out that issues with kidneys were not that prevalent. So from package insert, and that's the latest that the manufacturer has, so the renal failure is not that common. As you can see, the myelodysplastic syndrome, or this is a type of bone marrow disorder. Now we think that this is technically a cancer. So it was reported close to 2%. Acute leukemias were happening. Low blood pressure, heart failure, and neuroendocrine crisis. So really in everyday life, in everyday clinical use of lutotherapy, don't see neuroendocrine crisis that frequently, but they, however, reported that it was, in 1% of cases, it was present. So those are serious adverse reactions. So risks were rated in subsequent report by Dr. Sonbol and Dr. Hamdanison in 2020. They reviewed 28 reports that included more than 7,000 patients treated with PRRT for neuroendocrine tumors. And the median incidence of treatment-related cancers of the bone marrow, which here are called myeloid neoplasms, was 2.6%. This is reasonably high. So, and most patients were diagnosed at least 1 year after finishing treatment with PRRT, which tells you that it takes time to develop. So, and the other risk factors could not be assessed based on the information that was in those reports. So we were not able to tell from those reports whether the prior treatment with radiation or prior treatment with chemotherapy were risk factors for the issues with the bone marrow after treatment with PRRT. And this report was published 2 years prior. It's smaller number of patients, 274, data from Europe. So they reported that 11 patients had persistent issues with the bone marrow, hematologic dysfunction, 3.7%. So 8 of them had myelodysplastic syndrome, 1 had acute leukemia, and 3 patients had bone marrow failure. So which was demonstrated by cytopenias, which means low blood cell counts, and bone marrow aplasia, which means bone marrow was not producing enough cells. So, and the median onset that they reported was 41 months. So it's more than 3 years after the first treatment with PRRT. And again, they couldn't tell us if there were any risk factors in those patients. So now risks related to the bone marrow are probably on the top of the list of our concerns when we think about PRRT. And the Australian study tells us that risks might be higher in those patients who received concurrent chemotherapy. So they did this study, 104 patients were treated with lutetium-177. And at the same time, concurrently, they were treated either with capecitabine, which is an oral form of chemotherapy, or with temozolomide, which is another oral form of chemotherapy very commonly used to treat patients with neuroendocrine tumors. And out of 104 patients, 7 developed either myelodysplastic syndrome or acute leukemia, which came down to 6.7%. This is high. In physicians' world, in oncology world, this is high chance of issues, 6.7%. So median time to onset of those conditions for 5 years, anywhere between 2 to 7 years after treatment with PRRT was delivered. And now it is common knowledge that use of PRRT at the same time as chemotherapy is not recommended outside of a clinical trial. So this is an ongoing area of concern and area of ongoing research, concurrent use of PRRT and other treatment modalities. And back to issues with kidneys that initially were perceived as potentially a big deal. Turns out use of amino acids helped significantly, and rates of what we call nephrotoxicity, or damage to the kidneys, was reasonably low during treatment, around 1%. And this is European data that shows us that after the treatment, the average annual decrease in creatinine clearance, which is essentially the way to show how kidneys are working, was 3.4%. And no patient had an annual decrease in renal function of more than 20%, which is actually it's a very good number from doctor perspective. And in this study, they could not identify any risk factors for renal toxicity. So right now, from all practical standpoints, we do not think that risk of kidney damage is that significant, provided we use amino acids at the same time as infusion of PRRT drugs. So, and results, another classic paper by Dr. Strosberg, published in 2021, long-term outcomes in the later analysis. So overall survival, or essentially the amount of time that people live after the treatment was 48 months in those patients who were treated with PRRT versus 36.3 months in those patients that were not treated with PRRT, so-called control group. So it is, of course, clinically meaningfully significant from practical standpoint in everyday life. We know people live longer. Statistically, it was not significant, but there was a crossover, which was a good thing, which means patients in control group who were not treated initially with PRRT, but rather treated with somatostatin analog, upon progression, they were given a choice whether to continue with other treatment options or be treated with PRRT. And many patients crossed over and chose to be treated with PRRT, and obviously it affected the data. And other thing that we'll look at more and more frequently is quality of life. And it was shown that PRRT increases the quality of life in many patients. So time to deterioration of quality is an orthodox way to look at it from patient standpoint, but time to deterioration, or time to when the disease started affecting quality of life significantly. So this time was significantly longer in patients who were treated with PRRT compared to control group, higher dose octreotide, that was the control group. So in terms of global health status, median time to worsening of quality of life was 28 months in patients treated with PRRT versus just 6 months in those patients that were treated with high dose octreotide. And time to decline in physical functioning when cancer affected how people were actually performing their life was 25 months in patients treated with PRRT versus 11 months in patients treated with high-dose octreotide. So not only people live longer, not only disease controlled longer with PRRT, but quality of life is controlled longer. And in conclusion, I listed here the non-surgical treatment options that we do use in everyday clinical life to help patients with neuroendocrine tumors. And you see that somatostatin analog and peptide receptor radionuclide therapy that we just discussed is just a small part of the huge armamentarium that we have. from mTOR inhibitors to old-playing chemotherapy to targeted treatments, VEGF inhibitors, percutaneous ablative treatments that our interventional radiology colleagues are providing our patients to stereotactic radiation. So unfortunately, none of these treatments is curative. The only cure is actually surgery, and Dr. Bhagwandin will be talking about it. Like I tell my patients, nothing is better than the knife, but those treatments could stop tumor from spreading. They can stop neuroendocrine tumors from growing, or at least slow the growth. They can shrink in many cases. And in majority of patients, those non-surgical treatment options could ease the symptoms and people feel better. So thank you for your time. Speaking of Jupiter Medical Center, this is our beautiful Anderson Family Cancer Center. We are always here to help. And being in Florida, of course, there is a body of water surrounding our cancer center, practically from two sides. Thank you.
Thank you so much. While I have your attention, I will just ask a couple of questions, and then after Dr. Strosberg's discussion, we will open to general questions. But you highlighted some of the clinical aspects that you take into consideration for each patient, like their bone marrow function, kidney function, et cetera. Can you speak a bit about disease distribution or what you take into account in a patient who has a large mesenteric mass and the risks with PRRT there? Do you sometimes propose surgery before PRRT to control that risk?
Surgery is always on my mind. This is actually the first thing to consider. Question number one for every patient, because patient asks this question, and I ask this question, can the surgeon take it out? If the answer is yes, nothing is better than the knife. Must go out, because PRRT, as great as it is, so, you know, the objective response rate, the shrinkage of the tumor, I believe was shown to be found in 16% of patients or so. And 64, I believe, John, correct me if I'm wrong, and 64%, this was the initial report, disease became stable. So this is it, but it's not going away. It's not completely disappearing, unfortunately. That's why if surgery is an option, but by any means, surgery should be considered first. And as you well know, the mesenteric masses, it's a concern because with PRRT, frequently things get worse before they get better. And of course, there might be compromise of blood flow. And you know that in many cases, many oncologists who use PRRT would consider even treatment with steroids. But whether it's truly needed or not, it's very individual decision and it's on case-by-case basis. But lately, I think we are getting this impression that it might not be as scary as we initially thought, the mesenteric masses. But of course, if it's huge mass and it's completely surrounding the vessel, the risk is there. You have to take it into consideration. And other things to take into consideration, as I mentioned earlier, is the degree of bone involvement. If the patient has bone-predominant disease, the risk of bone marrow dysfunction after the treatment is probably higher. So far, nobody showed us the risk factors because probably of the trial design, but the common sense tells you that you have to be extra careful and you have to watch with problem increased frequency of blood work, what the bone marrow is doing, and potentially one would have a lower threshold for even stopping the treatment earlier. So that's in a nutshell how we look at the location and how we choose whom to treat with PRRT.
Thank you. I think that is important because sometimes there's an expectation that, you know, this should always be the next treatment, and it takes a careful, individualized consideration for each unique patient. I agree.
Absolutely. And essentially, we are in this situation when PRRT was just approved. If you remember, we were all expecting that there is pent-up demand and everybody will want PRRT, but now the wave goes down. So now it's less treatments are being delivered. Now we have less patients to treat and we have more treatment options. And obviously PRRT is always on our mind, but is it the first thing to do? Not always, not always. And now with this new data coming, showing if Australian data could be extrapolated on bigger population, on more patients. If truly the risk of bone marrow damage is 6%, this is something to think about, especially in younger patients who have, let's say, 40, 50, 60 years to live, and 6% chance of bone marrow damage. This is a big deal. And we really need to look at this subgroup of patients with bone involvement to see if it truly contributes to the increased risk of bone marrow damage. So this is a more paced approach, I should say now, to PRRT treatment.
Thank you so much. I'd like to, actually, our next discussion is what other options are there outside this focus on the somatostatin receptor? I'd like to introduce my colleague, Dr. Jonathan Strosberg, who is a senior member and professor of oncology at Moffitt Cancer Center. He is the program leader of our neuroendocrine tumor program. And he leads our research program for NET and our gastrointestinal oncology department. He has published over, I last checked, 200 articles on the diagnosis and management of neuroendocrine malignancies. He serves on the board of directors of our national society, NANETS, the NCCN guidelines for national guidelines, and the National Cancer Institute Neuroendocrine Task Force. Much like Josh, he is a great advocate for patients as well as a mentor to many physicians within the NET field. And I will hand it up to you.
Great, thank you very much, and thanks for everyone participating. I'm going to talk about other treatments other than somatostatin analogs and peptide receptor radiotherapy. So there's two main categories of treatment when we think about treating patients who have metastatic neuroendocrine tumors that are not surgically resectable. The first category is systemic, meaning whole body. These are drugs that can be given by mouth or intravenously that treat tumors wherever they may be in the body. And the subcategories I would consider to be, quote, targeted treatments that target a particular receptor or enzyme or genetic mutation. I put target in quotation marks because these drugs often are not quite as targeted as we'd like. And then cytotoxic chemotherapy drugs. These are traditional drugs that work by killing rapidly dividing cells through inducing DNA damage. And then we have, somewhat uniquely to neuroendocrine tumors, liver-directed therapies, because neuroendocrine tumors so often metastasize either exclusively to the liver or primarily to the liver. We can target the liver, and we can do that either with embolization, where we access the artery supplying the tumors and infuse microparticles either by themselves or mixed with another substance, or ablation, where we basically, in the past, freeze, these days mostly burn individual tumors. Ablation is primarily something done for patients with only a small number of tumors, like 1, 2, or 3 in the liver. Next slide. So the first systemic treatment I want to mention is everolimus. The brand name is Afinitor. It's an important drug because it's approved for a wide variety of neuroendocrine tumors, both in the gastrointestinal tract, the pancreas, and also the lung. It's a pill. It's taken once daily. It targets a certain enzyme within the tumor cell called mTOR. That stands for mammalian target of rapamycin. And we know that about 1 in 6 pancreatic neuroendocrine tumors actually have mutations in the pathway that involves that enzyme. But an even larger number of patients have upregulation of this so-called mTOR pathway. And so everolimus helps to block that pathway. It's used in other cancers as well, not just in neuroendocrine tumors. It rarely results in significant tumor shrinkage, but it can stabilize disease in many cases. Next slide. So, based on promising early phase data, meaning trials that were relatively small and non-randomized, 3 phase 3 studies were launched. And phase 3 studies are big studies where the investigational treatment, in this case Afinitor, is compared through randomization to something else. And the something else in all these cases was placebo. So these were placebo-controlled studies designed to test whether Afinitor managed to inhibit tumor growth compared to not taking any active drug at all. The first of these three studies was the RADIANT-2 study. This looked at patients with advanced metastatic neuroendocrine tumors and history of carcinoid syndrome, so history of flushing and diarrhea related to the neuroendocrine tumors. And as a result of that, it was mostly a study of small bowel neuroendocrine tumors, because these are the tumors that are associated with carcinoid syndrome. So patients were randomized to Sandostatin plus everolimus compared to Sandostatin versus placebo, with the possibility of crossing over if they progressed on placebo. And the primary endpoint in all these studies was progression-free survival, which you can think of as time to growth of the cancer on scans. So the red lines represent the placebo, the blue lines represent the Afinitor, and again, what we're looking for is time until tumor growth. And you can see that in all cases, it took longer for the tumors to grow in the patients that received everolimus versus placebo, but the degree of separation of the curves indicates to what extent the drug was beneficial. And you can see in the first study in patients with history of carcinoid syndrome, mostly small bowel nets, the curves are pretty close together, so the benefit was relatively low. The second study in pancreatic neuroendocrine tumors, RADIANT-3, compared Afinitor versus placebo. In almost all cases without patients also getting Sandostatin. And you can see that there was a larger separation of the curve. So on average, it took 11 months for the tumors to grow on everolimus versus 4.5 months with placebo. And then the last study, RADIANT-4, looked at patients with gastrointestinal and lung neuroendocrine tumors with no history of carcinoid syndrome. So mostly not small bowel, mostly lung, colorectal, stomach. And these, again, were randomized to Afinitor versus placebo, and none of the patients had Sandostatin. And in this case, on placebo, it took about 4 months for the patient's tumors to grow and 11 months with Afinitor. And that was, there was a very clear advantage to Afinitor. So despite low response rates, Afinitor managed to stabilize tumor growth compared to placebo. Next slide. So here we're looking at overall survival, and these trials were not large enough to really give us a sense of what happened to overall survival. And also there was crossover. Patients who received placebo in RADIANT-2 and RADIANT-3 were able to cross over and receive the active drug. So that interferes with our ability to interpret what happens to survival. But you can see that in the first study, RADIANT-2, actually numerically, patients lived longer if they had started out on placebo, which is never encouraging. For this group of patients with carcinoid syndrome, the drug didn't seem to help that much. Whereas in RADIANT-3, there was a small trend toward improvement in overall survival, again, attenuated somewhat by the crossover. And then in RADIANT-4, there was also a trend toward improvement in overall survival. So we think this drug in the appropriate population will increase survival, which is obviously the goal. Now, Afinitor does have side effects. It can cause canker sores in the mouth. We prescribe a steroid mouthwash to prevent that. It can cause high blood sugar. It can cause inflammation in the lung. That's called pneumonitis. Afinitor is an immunosuppressive drug, so it can increase the risk of infection. It can cause diarrhea and tiredness. Those are the main side effects. Another pill that we sometimes use, not that frequently, is sunitinib. The brand name is Sutent. This targets the vascular endothelial growth factor receptor. This is a receptor that involves growth of new blood vessels to tumors in cancer. And again, this is something that's not unique to neuroendocrine tumors. It's an important mechanism in many types of cancer. So Sutent interferes with that. Like Afinitor, it almost never shrinks tumors significantly, but it can stabilize them. And it was only tested in a large study in pancreatic neuroendocrine tumors. Next slide. So the pancreatic neuroendocrine tumor was very similar to RADIANT-3, which looked at Afinitor in pancreatic neuroendocrine tumors. Patients were randomized to Sutent versus placebo. The primary endpoint, again, was time to tumor growth, progression-free survival. And you can see that with sunitinib, the average time to tumor growth was 11 months, with placebo was about 5 months. So there was a significant improvement there, very similar to what we see with the Afinitor. Next slide. So side effect of Sutent includes high blood pressure. There can be a mild increase in risk of heart attack or stroke. It notably causes a painful rash on the hands and feet, on the palms and soles, to be specific. It can cause diarrhea and it can cause significant fatigue. So, you know, I wouldn't say that Sutent is necessarily easier or harder to tolerate than Afinitor. On average, it's about the same. And the outcomes in pancreatic neuroendocrine tumors are about the same. So those are the so-called targeted drugs. Then there's chemotherapy. And the chemotherapy that we use most often these days is capecitabine temozolomide. The brand names are Xeloda and Temodar. These are oral chemotherapy drugs. They're primarily effective for metastatic pancreatic neuroendocrine tumors. And unlike the former two drugs I mentioned, they actually cause significant tumor shrinkage on average in pancreatic neuroendocrine tumors. About half of patients have significant tumor shrinkage. So there was a study that randomized patients to receive either capecitabine temozolomide or temozolomide alone. And you can see that there was an advantage to receiving the combination. In fact, the average time to tumor growth here was over 22 months, so nearly 2 years. Roughly double what we saw with either Afinitor or Sutent, although those were different trials. And there was also a trend towards improvement in overall survival with the combination versus single drug. What are the side effects of CAPTEM? The main one is low blood counts. About 1 in 10 patients will have really low blood counts, low platelet counts that increases risk of bleeding, and in fewer cases, low white blood cell count, which increases the risk of infection. Otherwise, if it's taken properly, the side effects tend to be relatively mild on average. Very important, and it's something I'd like to emphasize to patients, because not all doctors in the community remember this. You absolutely need to take a nausea medicine called Zofran. Brand name, the generic name is ondansetron, 30-60 minutes before Temodar. Patients who don't take that get very nauseous. At Moffitt, we always provide patients with an instruction sheet because the regimen is a little bit complicated. It's a 2-week on, 2-week off regimen. The Xeloda is taken twice a day for 14 days. The Temodar is taken at bedtime for the last 5 days of those 14 days with the Zofran beforehand. So an instruction sheet and calendar help. So switch gears now to liver-directed therapy, which we do very often in patients with liver-dominant tumors. And the rationale for this is the fact that the liver has a dual blood supply. It's the only organ that has 2 blood supplies entering into the organ. Usually arteries enter into the organ and then veins drain the organ. But in the liver, you get both the hepatic artery and the portal vein feeding the liver. But the tumors get most of their supply from the hepatic artery. So by blocking branches of the hepatic artery, you can selectively kill tumor cells. And the way to do this is by threading a catheter, usually through the groin, going up the aorta, entering the hepatic artery, and then the branches of the hepatic artery, and infusing microparticles. And this basically blocks the blood supply. So one method is bland liver embolization. This uses any small part, there's many different types of small particles. One is called microembospheres. Then there's chemoembolization, where you basically mix in a chemotherapy drug. And then you can do radioembolization using an isotope called yttrium-90 that's infused into beads, either resin beads called cerspheres or glass beads called theraspheres. These are very tiny beads. There's a fourth thing called drug-eluting beads, but those are found to be in neuroendocrine tumors more toxic. So we really don't use the drug-eluting beads. The important thing to remember is that bland embolization and chemoembolization have short-term side effects. They cause pain in the liver area, nausea, sometimes fevers, sometimes a lot of tiredness. These usually resolve within a few weeks. Radioembolization using yttrium-90 is easier in the short term, but in the long term can lead to liver damage, especially if the entire liver is treated. So how does embolization work? Typically, patients are treated in stages. In most cases, 2 stages, first one side of the liver, for example, the right lobe, and then the left lobe a month later. But in patients with a lot of disease, you can break it up into smaller segments so you don't cause too much toxicity. So how effective is embolization? We have a lot of small, usually institutional studies, mostly retrospective, meaning looking back at experience. We don't have any really large prospective studies, although there is one that's taking place right now comparing bland and chemoembolization. We don't have the results of that yet. But based on this accumulation of data, we can say that on average about half the patients will have significant tumor shrinkage. And it's very effective at controlling hormonal syndromes like flushing and diarrhea and carcinoid syndrome, for example. There's a bit of a misconception that embolization can only be used to treat a small number of tumors in the liver. That's not correct. We treat patients with hundreds of tumors and patients with high liver tumor burden. So this is one example of a patient. You can see the dark spots basically occupying most of the liver. Next. But then after 5 chemoembolizations, you can appreciate significant shrinkage of tumors. And so you can treat patients with a lot of disease. One other treatment I'd like to mention is ablation. This is basically involves burning an individual tumor. So you insert a probe into the tumor. It really only works for patients with tumors smaller than 3 centimeters. And it also is only appropriate for patients with a few tumors, because once you get to many tumors and you start trying to burn all of them, the risk of a complication like an abscess increases significantly. But if you're dealing with a small number of tumors, you can actually get rid of them, almost like surgery. And this can be done in some cases through the skin, so you don't have to do an incision, using CAT scan or ultrasound guidance. So to wrap things up, when we look at small bowel, otherwise known as midgut nets, that are not surgically resectable, we typically start with a somatostatin analog, like Dr. Naraev said, either octreotide or lanreotide. And then if patients progress on that, commonly move on to PRRT with lutetium dotatate, Lutathera. If they have liver-dominant disease, we sometimes do liver embolization. Occasionally, we'll use everolimus Afinitor, particularly in patients who are not appropriate for the first 2 of these treatments. But as I said earlier, the evidence for everolimus in this group of patients is not as strong. Next. So other patients with neuroendocrine tumors originating in the lung or in the stomach or in the rectum, there's more options. Usually we'll start again with a somatostatin analog if the tumors express somatostatin receptors. Beyond that, there's these various options, and they're in no particular order. And then lastly, in pancreatic nets, we have the largest number of options. Again, in no particular order. We'll typically start with a somatostatin analog, but then there's everolimus, Afinitor, Sutent, Cap-10 chemotherapy, Lutathera, liver embolization. These are all individualized decisions. We are doing studies comparing some of these options. So in the future, we may have more information to guide us. And again, we need studies to tell us how to best sequence these treatments and really appreciate patients who participate in studies that help us answer these questions. Just one last slide. We're talking almost exclusively about well-differentiated neuroendocrine tumors. I don't know if there are any poorly differentiated neuroendocrine carcinomas, patients with these aggressive cancers in the audience, but these are tumors that are very, very aggressive. They look differently under the microscope. They're biologically different. They have different mutations that cause them. These are treated with chemotherapy, drugs, combinations like cisplatin etoposide, carboplatin etoposide, in some cases with immunotherapy. But this is clearly an area where we need to do a lot of research to improve what we can offer our patients. Thank you.
Thank you so much. I think this is a good time to pause and welcome any questions about medications used to treat neuroendocrine tumors before we pivot to the knife, as Dr. Naraev would say, and talk about surgery. please send your questions to our chat or the Q&A. And while we wait for some questions to go through, I think I would ask both my colleagues, I think you summarized well there at the end, Dr. Strosberg, that sequencing is not yet well understood, and you mentioned a couple of trials. Can you speak a bit about the trials that we have ongoing right now that are helping us answer the question between deciding when to proceed to PRRT versus another medication?
Right. So we had the COMPETE study, which looked at a slightly different PRRT drug, lutetium dotatalk, compared to Afinitor in advanced gastrointestinal and pancreatic neuroendocrine tumors. So that's going to be an important study, and hopefully we'll get the results of that this year. We're looking at the COMPOSE study, which looks at lutetium dotatalk versus other options in patients with relatively aggressive neuroendocrine tumors. Ki67, I think, is 15 to 55%, if I'm not mistaken. And that's a study in patients who have just received a somatostatin analog, so relatively early in the course of treatment. So those are two important comparative studies looking at PRRT versus another active drug. We also completed the NETTER-2 study, which looked at Lutathera versus high-dose octreotide in patients also with relatively aggressive tumors.
Thank you. And Dr. Naraev, there's a lot of discussion about expanding the realm of PRRT, and that, can you speak a bit about different medications that are currently being studied outside lutetium, some of which are currently in trial with us?
Sure. Well, there is a lot going on. Unfortunately, not much in Jupiter at the moment. But question of combination of PRRT with other treatment modalities is obviously a hot topic as well. There is research ongoing to evaluate whether the similar to Lutathera compounds could be used for liver-directed treatment. So instead of just doing chemoembolization or blunt embolization or embolization with Y90, could it be done for people with neuroendocrine tumors with the use of Lutathera-like compounds, which sounds very intriguing, and I know in many countries it's actually routine clinical practice, but obviously the data is needed. So in terms of PRRT, the big time research going on in terms of retreatment, because we got to the point, and we knew we will be there, that people who had PRRT before now have disease progression, and there is a question what to do next. Would people be treated again? And we know that they could, but more data is needed, because in Europe people treat for many cycles. Again, so solid research is needed, and it is ongoing. As well, different isotopes. The same Y90 is being studied. So alpha emitters are being studied in patients with neuroendocrine cancer. So there is obviously a lot of exciting developments. We can't wait for those trials to come to fruition and give us some numbers and give us more treatment options.
Yeah, I should mention we have 2 alpha emitting studies, and I know that's an area of a lot of excitement. These basically emit much heavier particles than lutetium at a shorter particle range, and potentially can induce more, tumor damage and higher response rates. So one looks at lead dotamtate. We hope to be opening a cohort shortly for patients who have already received Lutathera. We completed the cohort of patients who had not received PRRT before. And we also will be opening the phase 3 Action 1 study looking at actinium dotatate compared to other standard of care treatments in patients who have already received Lutathera. So both of these studies should be open and have slots in the late spring.
I think that the welcome challenge in treating neuroendocrine tumors is that it's a lot of options. They're not quite sequenced, but it does allow a more personalized approach to each patient instead of being limited to just one choice each step of the way. And so it's exciting that it continues to grow. Josh, did you have something to add?
No, I mean, we're also going to have an NCI-sponsored retreatment trial with lutetium as well that will hopefully open at some point. And I think one of the challenges is going to be we're going to have a lot of trials open, and how do we figure out how to make sure that we can accrue and get an answer to those? You know, looking at, you potentially have two alphas and a beta, we should open a supermarket. And how do we determine as a patient, and just even on top of that, I'm just going to go on the riff of PRRT. We have several trials open with other combinations of drugs with PRRT, I think, as was mentioned. How, as a patient, are we going to choose or know what is the path for us? Even as physicians, I look at some of these and with combinations, and I'm trying to figure out what the nuance is that I would put someone or work with someone on one trial versus another. So how do we deal with all the things that are coming down the pike and making sure that this is somewhat understandable for those of us who are going to actually enter into them?
You know, that's a good question. We have had issues in the neuroendocrine tumor community of trials just some trials not accruing. Some trials accrue very quickly and very well. Others don't accrue. You know, I think physicians should, you know, do their best to try to open studies. It's not as easy as it used to be. There's a lot of barriers and difficulties and bureaucracy involved in getting studies open. It's also very expensive. So, yeah, but our goal should be, you know, offer trials to as many patients as possible.
You know, I'm fearful, but I'm not fearful, but we have a LungNet trial that is open in PRRT. I think that's versus everolimus, and I think we're going to see recruitment shortfall for that because of the length of time that it took to open, and also that LungNet patients now can get PRRT off-label, but we'll end up, you know, and I'm appreciative of every study that turns out and said more studies needed. But if we don't finish a study, we'll never actually get the answer. So here's an issue where we don't have the answer, and because it took so long to get the trial open, and that, at least this is my interpretation, that we won't, you know, we'll never get this answer, right? I mean, I think of the SpinNet trial and trying for lung nets and lanreotide, and not that we're going to answer the world's problems here, or at least the net world's problems, but we've got to think through this, and I think your point that you know, participating in clinical trials is always a good option that can help us answer these questions for those who come, for us patients who come after, that can help clarify that road for us. But I think that's another reason to always consider a clinical trial. So thank you guys for continuing to do what you do.
Tamia, did any questions come through to you?
No questions that I see. I know Josh had mentioned that the trial that Dr. Naraev brought up was with the MDS risk, was one that included patients who received capecitabine, temozolomide. So just a note for the audience.
Yeah, simultaneously. I mean, I think that was the ControlNet trial in Australia, and I think that one was where they were, and this is, I mean, we talked a little bit about this yesterday, but, you know, informed consents, I think one of the challenges as patients, especially in these combination trials, is understanding what the toxicity of combined agent might be, where we kind of have some idea of what they are separately, but where you're trying to consent us on a trial that may not we may not completely know what the combination or even have a good guess of what the combination toxicities are, and how do we evaluate some of these combination trials for us to participate in, or what should we be looking for is a better question. What could you help us with that would help us better understand those combined toxicities?
Well, the first answer is, of course, that you don't know until you try, right? So, and we still, it's hard to say for sure because the Australian study was a small study, but I think there's accumulating evidence, for example, that chemotherapy plus PRRT, either combined or sequenced, probably increases the risk of long-term bone marrow damage. As far as combinations in general, I think what we should be looking for are combinations that, truly have a good rationale that the sum of the two treatments will be better than the combination of the parts, right? That's what we mean by synergy. I mean, there's a tendency in oncology to just throw two drugs that are active together because you can, but rarely do these actually result in better outcomes than sequencing the two options. So, we need to try to find combinations where things where it helps improve outcomes without adding too much to toxicity. So there was a trial that was mentioned, a PRRT plus triapine, which is a radiosensitizer. I mean, I think that's a good example of a trial that might, that meets that principle potentially. Or capecitabine temozolomide, where the capecitabine doesn't really add much to the side effects on average.
And if I may add, Josh, I agree with you. It's a matter of informed consent. Patients need to know that clinical trials are great. That's what moves us forward, but this is not an easy walk in the park. So it's a trial. We are given it a trial. We don't know what can happen. It's always a risk, and people need to have a very clear understanding. And back to our discussion yesterday, at what grade level the consent should be written, because people need to clearly understand that this is not always fully great, because people tend to hear about, miracle drugs like Rituxan. Remember, people still alive, those who run phase 1 trial. But not every drug is Rituxan, not every drug is a miracle, and risk is there.
Thank you. For the sake of time management, we will move on to our next topic of discussion, but we will revisit a Q&A thereafter. So I'd like to introduce my colleague, Dr. Bhagwandin. He is the medical director of the Gastrointestinal Surgical Oncology Program and the program director of the Pancreatic Cancer Center of Excellence at Jupiter Medical Center. He's a fellowship-trained surgical oncologist, and his clinical and research interests include the diagnosis and treatment of complex malignancies of the liver, pancreas, biliary tract, colon, as well as sarcoma and melanoma. And he delivers compassionate care with the goal of restoring patient well-being. And so he will discuss surgical management of small bowel mets. Thank you so much.
Thank you, Mena. And I really want to say how appreciative I am to be a part of this panel, because I think obviously not only is it an important discussion, but just with regards to the need for expertise here, specifically at Jupiter Medical Center, and having Dr. Naraev here now locally. I know we share a lot of patients across the state, but certainly doing a lot for our patients within this capacity. So my talk is primarily focused on when is surgery feasible, and specifically with regards to small bowel neuroendocrine tumors, not so much pancreas, lung, et cetera, but looking more at well-differentiated low-grade tumors in the context of liver metastases. So I have no disclosure, but to take a step back, at least for our patients, why the zebra is associated with neuroendocrine tumors, and why NorCal has done such a creative use of putting it within the zebra. But if you don't suspect it, you can't detect it. And medical students have been taught for decades that when you hear hoofbeats behind you, don't expect to see a zebra. In other words, you look for the more common and usual, not the surprising diagnosis, but when you see a zebra, you know it's a zebra. Neuroendocrine tumor used to be the diagnosis. It used to be that exotic diagnosis that you read about, but they're obviously becoming more and more frequent. And in that capacity, we obviously are looking for more and more ways to treat them. And Josh, I want to get one of those fancy jackets.
I only had women's extra small with me, and I didn't see what would have fit women's extra small with me yesterday. So, but we have others. Don't worry.
I'll hold out. I'll hold out.
You'll hold out.
Fair enough. But speaking just with regards to how common they are, obviously the prognosis for patients with neuroendocrine tumor, it's significantly better than for most other cancers. The data shows that patients can live for years despite having many tumors and metastases. There's a significant difference in how aggressive tumors are, even in the same organ, and they may behave differently in different patients. So this is from 2008, but just looking at the SEER database, 28,000 cases showing that 50% of patients typically present as localized, so confined to the small bowel specifically, and the remainder either have locally advanced disease where it's spread to nearby lymph nodes, or already have metastatic disease and commonly to the liver, which we'll talk about today. So as a result, prognosis often depends on the localization of the primary tumor, consideration for symptoms, of course, in the presence of metastases, specifically where and the number of tumors, as Dr. Strosberg alluded to. The grade of malignancy is obviously key, and that's defined by our expert pathologist, Dr. Soaita, who will speak next, as well as the presence of biomarkers within the blood and the presence of cardiac insufficiency and specifically carcinoid heart disease. But overall survival, even with metastases, has improved due to the development and use of the treatments that were mentioned previously, and obviously in conjunction with surgery when available. So small intestinal neuroendocrine tumors are the most common cancers of the small intestine, mainly found within the last few feet of the small intestine, named the terminal ileum. They're usually focal, slow-growing tumors, often less than 2 centimeters, about a fingertip size. And about a third of cases, however, can present with what we refer to as multifocal disease or multiple tumors throughout the small intestine. That's more noted in meters in size, which means that there are multiple tumors sort of scattered throughout the small intestine. So in an operation, even though there may be a tumor that's identified a lot by the CAT scan findings, it's important to run the small intestine from start to finish, because that's one way that you can pick up on smaller tumors that aren't identified either on imaging or grossly on exam. Most patients with a small intestinal neuroendocrine tumor will have non-specific abdominal pain, which is usually caused by fibrosis related to the tumor, what's referred to as desmoplastic reaction that's showed there in the picture in the top right. But sometimes small bowel obstructions can be the first sign of metastatic disease, or at least locally advanced disease. The gold treatment, or the gold standard treatment, which can be curative in a lot of cases, is to obtain what's called an R0 resection, and that you remove the primary tumor surrounding lymph nodes with negative margins and clear the disease. But if patients do present at an advanced stage, a diagnosis, surgery can be limited, but the aims to reduce the disease burden in order to improve survival is evident specifically with this pathology. So even with advanced stages, patients that present with operable or resectable disease, they do have a better prognosis than those with inoperable or advanced disease, which may be straddling the small bowel blood supply, which some of the pictures here identify, or innumerable liver metastases that would preclude any sort of resection. An interesting topic with regards to when is surgery feasible does also point to carcinoid syndrome. So there's a need, obviously, for a thorough preoperative evaluation and treatment of those symptoms, where we might need to monitor that, because obviously patients are dealing with diarrhea. There's certainly have a component of dehydration where they may need ongoing fluid resuscitation, as well as initiation of somatostatin analogs preoperatively. And as I mentioned, carcinoid heart disease does have an incidence of about 37% that don't have any physical signs of that, but obviously the workup certainly needs to accompany any preoperative planning if a patient is about to undergo a pretty extensive debulking. So certainly tumor markers, biomarkers, as well as symptoms of flushing are associated with carcinoid heart disease, and a cardiac workup, which would suggest an echocardiogram to look for any valvular disease. In the context of carcinoid crisis, which is something that can develop intraoperatively, where that patient can have, cardiopulmonary respiratory embarrassment, et cetera. The most common manifestation in the OR is typically hypotension, low blood pressure. So typically we have to initiate patients on octreotide drips via protocol, as well as the role for subcutaneous administration prior to surgery. Approximately about 80% of patients that have disease-related deaths ultimately die due to liver insufficiency. So an overwhelming amount of liver disease. 16% ultimately succumb to their disease due to bowel obstruction. So surgical intervention may help improve survival and quality of life in certain cases, particularly even if the context is palliation or treating those symptoms. Traditionally, let me go back. The guidelines for surgery, and this is sort of the summary slide for this talk, just in terms of saying when is surgery feasible, but this was traditionally what was described with regards to being able to obtain, again, that R0 resection with regards to a negative margin, grade 1, 2 metastatic tumors, acceptable morbidity and mortality, meaning death and complications related to surgery, in the absence of carcinoid heart disease, in the absence of peritoneal disease, which refers to when these tumors can spread throughout the abdomen, and what was quoted as 70 or even 90% of metastatic liver disease, if that was achievable in terms of being able to remove those tumors, that was, again, traditionally what was looked at in terms of obtaining a clinical benefit. But more recently, and with the guidance and expertise of NANETS, those guidelines expanded to include patients with any number or size of metastases, intermediate grade, as well as extrahepatic disease, provided that number still holds true, that you can remove about 70% of tumors by way of debulking, and achieve the same sort of outcomes in terms of survival benefit. So as a surgeon, I like to show surgery, but if anyone is a little too squeamish or doesn't want to see this video, you can obviously look away. It's just a quick video of an operation of the liver, but it does show these carcinoid tumors. This patient needed a bowel surgery for a neuroendocrine tumor in the small intestine, had little small tumors sort of scattered throughout the liver that were identified preoperatively, and these are carcinoid tumors. And you can shell them out very superficially and virtually no liver margin, very simple. This is another example of using our best invention ever, which is your finger. And you can actually reach inside the liver and feel these tumors. This is the capsule of the liver that was open, and a blunt sort of digital finger dissection, and very effective way to remove shallow tumors. It looks scarier than it is, but I've done this before, and that's obviously the tumor once it's out. And I'm almost embarrassed to show that video because it almost reduces complex liver surgery to glorified pimple popping, but that's ultimately, it just speaks to what carcinoids are like. And I think most illustrative of the properties of these tumors, that they're small, round, they're not invasive, they're not growing specifically within the liver parenchyma or tissue, and they're well encapsulated, that you couldn't do this with any other tumor in the liver, and they're really amenable and totally unique in the cancer world. That being said, a more traditional approach to liver metastases, especially when surgically amenable, is liver resection. And the benefit there in terms of what we quote as 5-year survival is upwards of 60 to 80%. We do know that about 95% of those patients throughout their lifetime will demonstrate recurrence. And a lot of it is really in the context of saying, well, when is the right time to go in the context of liver metastases to debulk the liver. But as I mentioned, studies have showed that the debulking with removing about 70% of the liver tumors does improve 5-year overall survival of about 75%. So in contrast, the liver metastases from other types of cancer that do spread to the liver, surgical intervention for metastatic disease doesn't necessitate that negative margin or R0 resection in terms of saying that you need to get more liver around these tumors, which would be the optimal approach, that being said. But the rationale is that, again, the doing what that sort of dissection does, which is a nucleate or sort of shell out the tumor, is an acceptable approach in terms of preserving liver volume, particularly because patients do progress and die from liver insufficiency if you do major liver resections and remove lobes of livers, et cetera. So there is a need to preserve as much liver as possible in terms of survival benefit. Dr. Strosberg talked a little bit about ablation, and combining surgery with what's referred to as microwave ablation is a feasible approach, again, for preserving that postoperative liver function, and that if you have tumors that are deep within the liver, that it would necessitate removing a significant amount of liver to get to a small tumor, et cetera, is that you can direct the needle within the liver and burn those tumors and kill them with a high success rate. So in combination with surgery, we will often use a combination of surgery as well as microwave ablation at the same time to debulk the liver to meet that 70% metastatic burden removal, just to make sure that we can obtain the appropriate clinical benefit. But there are multiple approaches in the therapeutics of liver metastases, in this context specifically being microwave ablation. And obviously, a lot of our neuroendocrine tumors, they do provide a clinical challenge because they are heterogeneous group of malignancies, not just small bowel, but certainly pancreas with function, high grade, low grade, et cetera. And they have a wide range of morphologic, functional, behavioral characteristics that have to be taken into consideration, particularly if you're considering surgery. So we do tend to bridge a lot of our recommendations by way of consensus of a multidisciplinary group of not only myself as surgical oncology, but medical oncology, our nuclear medicine and interventional radiologists, and that obviously forms a multidisciplinary tumor board to come up with a consensus where the patient is obviously a key component of that. And having an opportunity to be a part of the discussion yesterday with Josh, I think obviously patient advocacy also plays a significant role in terms of awareness and how we communicate that information from a language perspective, as well as integrating the patient in terms of our discussions, because it is and can be a difficult diagnosis to treat. But that's just a glimpse with regards to the indications for surgery, when to operate, et cetera. So wanted to share that with everyone, and obviously if any questions, or we have a Q&A at the end, happy to answer any questions.
Thank you. I know it's a lot of pressure to review surgery in a short amount of time, but thank you. I think that summarized a lot. And I agree, before your last slide, I was reflecting that the unique biology of well-differentiated tumors that allow surgery really demands a multidisciplinary review and access to a team that treats neuroendocrine tumors routinely There are many times where I've met with patients with metastatic disease and they were told that surgery is not feasible simply because, you know, they had tumors that had moved from the small bowel and to the liver, but not really looking at the biology of the tumor. And in fact, they did have surgery thereafter. Before we move on to pathology, and we do have a Q&A after that before we wrap up, a question to you that I know my surgical colleagues, you know, address and maybe my medical oncology colleagues can also discuss. How do you reconcile the risk of recurrence being high when introducing the concept of surgery to your patients or to our patient attendees?
Yeah, great question. I think, you know, symptom control is one aspect of that conversation with regards to whether or not debulking will, you know, prevent any further or mitigate any of the symptoms. At that particular time, I had a mentor that used to say it's not so much if you're going to operate, but when to operate. And it's really just assessing, obviously, the biology of that disease in terms of well differentiated, as well as the morbidity associated with the liver resection. And a lot of the times, if we can do a minimally invasive operation, and we know sometimes the imaging may underestimate the disease that's there, but that often lends itself to saying, well, an upfront approach with regards to surgery and debulking will at least address some of the disease that we know is there. And if we can obviously render that patient without evidence of disease, there's an opportunity to at least treat it. But knowing, obviously, as you mentioned, the 95% recurrence rate and the high recurrence rate, is that it really is a conversation with the patient to say, well, we know these tumors to be slow growing and no one really knows or can predict in terms of timing. But if ultimately we can debulk the disease now and prevent things from any existing tumors from progressing, et cetera, in the context of making it inoperable, sometimes that just ends up being the conversation to facilitate a surgery.
I agree. And I think sometimes surgery, especially removing bigger small bowel masses, opens up a window for other treatments and controlling the risk. So, you know, or future obstruction or symptoms, as you mentioned. But it also is a tool to make a longer chronicity of the disease in the future. So it's an important tool to look at. So I think that it's an important discussion to have, but recognizing the ultimate benefit of being able to do surgery. Thank you so much. Dr. Soaita is the medical director of the Department of Pathology and Laboratory at Jupiter Medical Center. She is a board-certified anatomical and clinical pathologist. And her areas of interest are surgical pathology, gastrointestinal oncology, liver, pancreas, and breast pathology. And she's going to be discussing some unique concepts regarding the pathology of neuroendocrine tumors. Welcome.
Thank you. Hello, everyone. I'm here to take you to the backstage of pathology that you don't usually meet the pathologist and our team. So there's a whole team that receives and prepares the specimens, and the pathologist evaluates the tumors and gives all the information possible to your oncologist and surgeons and everyone involved in the care. I don't have a camera on my desktop. I apologize. You already heard most of everything in the previous discussions, but I'm here just to talk about the basics and what we do in pathology. So just in general, neuroendocrine tumors, a tumor in general doesn't mean cancer. It's just a growth, like a bump on abnormal bump in your body that can be seen or felt. And neoplasms are new growth tumors that can grow on their own, and they can be benign or malignant. Malignant meaning cancer. They can spread to other organs and be destructive. So neuroendocrine tumors may behave, they have the potential to behave like a cancer. And again, they're not all cancers except for the ones that are called neuroendocrine carcinomas, that no matter how small they are, they're always cancers. And then the neuroendocrine tumors are well differentiated, and we'll talk about that. And they have different degrees of them, better differentiated and less well differentiated with different behaviors. But those are the tumors that have the potential to behave like cancer. But if they are removed soon enough, you may stop their spread. So there are tumors that resemble neuroendocrine cells, the normal cells, which have traits similar to nerve cells, hence the word neuro, and they can detect certain things in the body called stimuli, for example, low glucose or high glucose, and they can produce hormones to regulate different functions, for example, hyperglycemia or hypoglycemia, and help different functions in the body, and they may stimulate further other production of other hormones. So neuroendocrine tumors are this tumoral growth, so new growth that resemble the neuroendocrine cells that are present in many parts of our body, many organs, most commonly in the gastrointestinal tract. Second most common is lung, and then pancreas, and there are other organs where they can occur as well. They're a very diverse group of neoplasms, of tumors, from very slow-growing ones to very fast-growing ones, and we were talking about the fastest-growing ones are carcinomas. And this is determined when we look at the tumor. We can tell everyone involved in the care how does the tumor look, how well differentiated it is, and the grade, meaning how fast the tumor grows and what to expect from that tumor. So they can be the slowest growing cancers, such as the well-differentiated neuroendocrine tumors, grades 1 and 2. And you can see here this, the second picture, neuroendocrine tumor G1, G2. These tumors resemble very much the normal neuroendocrine cells in the body. And here's an example to the left, a picture to the left of an example of an islet Langerhans of the pancreas that produces glucagon and insulin. And you can look at the cells, and they're very similar to this low-grade tumors that you can see in the second picture. So the low-grade tumors, well differentiated, the best differentiated, they resemble the normal cells, and they're better behaved in general. And as they become more aggressive, they're categorized as grade 3, so higher grade in general in pathology. The higher the number, the more aggressive the tumor. So the lower the number in general is better prognosis. So here, the third picture, you can see a still well-differentiated neuroendocrine tumor, but at grade 3, so a little more faster growing. It doesn't resemble the normal tissue as much. And then to the right, you see a neuroendocrine carcinoma that is completely transformed. You don't even recognize it as resembling the normal tissues. So the differentiation, meaning we describe the tumor, we have to say what kind of tumor it is. We do that by looking at the tumor by routine staining, which I really like Dr. Bhagwandin's video. So that little tumor that he takes out, or sometimes it may be taken out through a biopsy from outside the body, through a needle, or going into doing a colonoscopy or an upper GI study. Biopsy is taken, that comes to pathology and formalin fixes the tissue, makes it a little harder, and fixes the proteins and allows it to be processed further and cut and obtain thin sections, which are placed on a slide and are stained with routine pink and blue stain. So we look at that and we see, yes, this is probably a neuroendocrine tumor, and we do additional studies to confirm that through antibodies, which support our first impression on the routine stains. And here are some of the stains we use. Here's an example of synaptophysin. Another one is chromogranin. These are cytoplasmic staining. They stain all around the cells. And then we have stains that are nuclear stains, which you see here on the right, the nuclear, this brown dots. And this is an example of an INSM1, a newer stain that we use. And another newer marker that is not so new, but there was a lot of work being done to find the best antibody to detect somatostatin on receptor expression on the cells. So here it is, somatostatin receptor 2A. It stains similar to synaptophysin. So this is a marker that we see mostly in small intestinal tumor as well as pancreas. And you've heard a lot about the somatostatin receptor in the previous talks. And here we in pathology, we can stain these tumors and show how much expression of this receptor is on the cells, and we can, and this correlates, we can predict how well these tumors may respond to radiotherapy with radiolabeled somatostatin analogs, as well as how well the radiologists can see with special functional scans, potential metastasis from these tumors. And it's a very useful tool used in combination with all the clinical information that we have. Another stain that we use is a keratin, which is a stain that is used in other type of tumors called carcinomas. And that's where the name carcinoid, the old name carcinoid, came from. When they were initially described, they were tumors that resemble carcinoma, carcinoid. So they do express keratin, which is actually very important in the diagnosis. Most of the neuroendocrine tumors express keratin, which should be demonstrated at the time of diagnosis. We identify what kind of tumor it is under a microscope, and then we describe it further, categorize it as best as possible with describing the tumor grade, basically describing the potential behavior of that tumor, as well as we'll see further the stage, the pathologic stage. So the tumor grade usually goes hand in hand with the differentiation. So the better differentiated tumor, the grade is lower. And as the tumor loses its resemblance with the normal cells, they're usually higher grade. And we do that by looking for mitosis, and mitosis show us how fast the tumors, the number of mitosis, how fast the tumor divides, and also by the Ki-67 index. So we look for both of them, but we always do the Ki-67 index, which is a similar stain as you saw before that we use for differentiation. This is a nuclear stain, and you can see the brown dots. Those are the nuclei of the cells. So Ki-67 detects some small proteins in the nucleus that tend to accumulate while during the replication of the tumor. So as the tumor gets ready to divide, gets ready to undergo mitosis, basically division, they accumulate this protein, which can be detected by this study. And this protein is not present in the tumors while they are resting, as you see the light blue dots around. So those tumors are just sitting there. So we use whichever is higher, mitotic count or Ki-67 index, which is the percentage of cells that are staining brown out of the total cells that are counted. So usually we count several hundred tumors in the hotspot areas, so where the tumor grade would be highest. So here's to the left a very well differentiated tumor, grade 1, where the Ki67 is usually 1, 2, and no more than 3%. Only a few nuclei are staining. Here's a intermediate grade, well differentiated neuroendocrine tumor, where the Ki67 index is a bit higher, but less than 20%. Usually it's much less than 20%. And then when it gets to be more than 2%, those are the grade 3 tumors. That basically tells us these tumors are growing faster and they multiply faster, so therefore they grow faster. And neuroendocrine carcinomas as well, they usually have a very high Ki67 index, but usually even higher, more than 50%, sometimes close to 100%, such as small cell or large cell neuroendocrine tumors. Another thing we do in pathology and express it in our pathology report is describe the pathologic stage. So if we have just a biopsy, we just talk about the type of tumor, the differentiation, the grade. And then if we have a resection where the small bowel or the pancreas was removed with the lymph nodes and possibly other lesions that were suspected to be tumor, then we put that in a synoptic format and describe the stage of the tumor based on the based on the specimens we received. So that has 3 components. The P is for pathologic. So it's basically the T for tumor, N for lymph nodes, and M for metastasis, which are distant aside from the regional lymph nodes. So usually these are, every organ has its own pathologic stage criteria. Usually the tumor stage is based on the size of the tumor and the extent of the involvement of the adjacent organs. So if it bothers the neighbors, for example, if it extends into adjacent organ, but not spread to another side. The nodal status, we look for all the lymph nodes and evaluate them all under the microscope to see if there's tumor that's spread in those lymph nodes. And if we receive the specimens away from the tumor to evaluate for the presence of more tumor at those sites, those are distant metastasis. So for example, if we received a segment of small intestine with tumor and lymph nodes, on that we evaluate the tumor stage and the nodal stage. And if we receive that little tumor that Dr. Bhagwandin showed he took out from the liver, we look under the microscope to confirm that that's also tumor, and that would be a metastasis. If we don't, because there weren't any, then there's no pathologic description for metastasis. In the next slide, I outlined a simple pathology report for a resection specimen. Usually they're much longer, so we describe more things, but these are the key elements to look for. And we have, so as I said before, an example, small intestine resection. We describe the tumor, well-differentiated neuroendocrine tumor, the grade. Obviously, we describe all the studies we do as well. And very important, we put in there the Ki67 index, which we sometimes we may perform it on multiple parts of the tumor to give the best interpretation. And then the tumor stage is based on, like I said, the tumor size as well as how big the tumor grew. So in this example, the tumor involved the muscular dyspropria, so meaning the muscle of the bowel. And then we evaluate the margins of the resection. There was no tumor at the so the surgeon removed the whole tumor. The margins of the specimens are uninvolved by tumor. Another thing we look for is lymphovascular invasion. That's the way the tumor goes towards the lymph nodes. And then we evaluate the lymph nodes. This is an example with metastatic tumor in 2 out of 20 regional lymph nodes. And the stage here is PT2, PN1, and it's again for tumor and lymph nodes, and the metastatic status is not assigned based on the specimens we received. Of course, this is only what we have at this point in pathology, and everything has to be put together with the clinical, all the other clinical factors that we have for this case. So this is very probably back in the day, the pathology had more of a say, yes, this is what it is, but we also didn't have all the help from all the immunostains and all the other studies. But now we work closely together with all the specialties, and we correlate and we integrate all these findings, and we help each other give the best diagnosis and the best avenues for treatment. For example, these tumors, we diagnose as well-differentiated neuroendocrine tumors with a low Ki-67, so low proliferation index. It correlates very well with especially in the small bowel pancreas, with functional scans like a dotatate scan, where the tumors would be brightly showing brightly on those scans, as opposed to carcinomas, which have this Ki-67 that is much higher, and those will not show brightly on those scans, but they will show brightly on other scans, such as the FDG scans. So we can check on each other, which is really good, because we get feedback and we can get better at what we do faster. So it's wonderful. Thank you very much. I'm here for any questions about pathology, if you have any.
Thank you so much, and thank you for the example pathology report, which is often a topic of discussion in clinic, and it's such an important factor when I meet my patients as well. And I think you really spoke to the spectrum of disease that we encounter in the realm of neuroendocrine oncology, and we can be quite specific to each unique tumor based on the information provided by our pathology colleagues and their expertise. So I'll stop here and allow some time for Q&A.
So yeah, I just want to encourage the patients participating to ask questions, because that's really what this is meant for. So, any question whatsoever that comes up, please go ahead and ask.
So I have one for the surgeon and the oncologist in the room. I got this one yesterday on one of our meetings. Things have changed a little bit with the recommendation of gallbladder removal during surgery. I know when I was initially diagnosed, almost anyone who was having surgery had their gallbladder removed with the assumption they were going on long-acting somatostatin analogs, and that it would better to have it out now than, a third of a chance that you'd have an emergency gallbladder surgery down the road. But my understanding is some of the surgical thinking of this has changed, and just wanted to see what the update was, because it goes in patient groups all the time that you'll have your gallbladder out, and we've had several patients who don't.
Yeah, great question. I mean, it is in terms of how we assess symptoms, and even part of that is just to see if patients have any pre-existing symptoms related to gallbladder disease, and especially with regards to their workup, if in fact they do demonstrate evidence of gallstones within the gallbladder. But obviously the difference with this patient population is primarily geared towards future treatment with somatostatin analog. And a lot of that decision is that if patients, at least with regards to current guidelines, do recommend cholecystectomy during removal of the primary tumor, if in fact patients do have gallstones and gallbladder disease that would lend itself to a future issue.
I was not aware of any change in guidelines. Generally, it's thought that, well, we know that somatostatin analogs can cause gallstones. It's rarely clinically significant. So, but it's also fairly straightforward to remove the gallbladder during abdominal surgery. So, certainly in patients who already have metastatic disease, who almost certainly will be getting a somatostatin analog, it makes sense to me to continue recommending removal of the gallbladder, but certainly not mandatory.
Yeah, I think that the key distinction there is probably if they're symptomatic versus asymptomatic in terms of how prophylactic cholecystectomy is looked at. But obviously, if they are candidates for somatostatin analog, that honestly ends up being a part of the discussion with regards to future treatment and prevention of any acute biliary tract symptoms.
We welcome any question.
You all have the opportunity to ask questions, so that should work. You should just unmute yourself.
Hello, can you guys hear me?
Yeah.
So with respect to neuroendocrine carcinoma, I know that a lot of this information is not related to that so much, but with regards to a very positive response to carboplatin and etoposide, and then immunotherapy and finding on FDG PET scan, no uptake. What are your thoughts on maintenance with respect to that?
Do you mean maintenance immunotherapy?
Yeah. Or stopping immunotherapy at some point, or.
Right. So immunotherapy, refers to the so-called checkpoint inhibitors that basically inhibit proteins that prevent lymphocytes from interacting with the cancer. They work well for a minority of patients with poorly differentiated neuroendocrine carcinomas, probably somewhere in the 10 to 20% range. But when they do work, they can work quite well. And there are some predictive factors, one of them being a high tumor mutation burden that can predict who may respond. But, generally these drugs are meant to be given relatively long-term, the checkpoint inhibitors. The standard, in fact, is 2 years, unless there are, significant side effects that prevent that. Whether there's a benefit beyond that is hard to say. But the standard for immunotherapy is 2 years.
Yeah.
Okay.
I agree with Dr. Strosberg, because this is actually a very, very common question. And the great thing is that the PET scan is not showing anything anymore. It means there is a response to treatment. And its response to the treatment, immunotherapy was the part of. It would only make sense to continue long-term, as long as there are no side effects.
I think you were going to have a follow-up question to that, Ms. Carenti?
Well, I was just saying, I had read 24 months, but then I had heard that some people were on it for, years. So that's kind of why I was like, how long can you be on that?
In theory, you could remain on these drugs indefinitely. The thing is that once the immune system is primed, it's unclear whether there's a benefit in continuing it, beyond a 2-year time point. At least, the doctors that have the most experience with this are those that treat melanoma, for example, and that's where we draw our conclusions from. So there's almost certainly from the mechanism of action standpoint, there's almost certainly no reason to continue with the checkpoint inhibitors once the immune system has been primed to target the cancer. But it's also pretty harmless to continue for a long time.
Okay, thank you.
I have a question from an attendee that for surgery says, wouldn't getting any safe amount of tumor out of the liver be positive regardless of degree of disease burden?
Yeah, so great question, specifically in the context of liver recurrence and how high that is, but studies have looked at that with regards to whether or not lowering the threshold of 70% offers any benefit with regards to liver-specific cytoreduction, and that's more speaking to small bowel tumors. But even in the context of looking at survival benefits, symptom management, et cetera, is that the benefits still hold true if greater than 70% of cytoreduction or liver debulking in terms of palliation, symptom management, and of course survival benefit holds true, which is what our current North American guidelines support.
It's also important to emphasize, for most cancers, which tend to be more aggressive, even removing 90% or more of the disease doesn't impact survival favorably. So neuroendocrine tumors are actually the exception, that if you can remove a lot of disease, there seems to be a long-term benefit. For most cancers, that's not the case.
I think the concept here is there's a defined minimum to achieve to have that gain.
Yeah. All right, looks like there's no other questions.
Okay. Well, I want to thank everyone for joining, especially our patient community. Thank you so much for your time this Saturday morning. Thank you for your questions and your attention. We hope to do more of these, probably in a hybrid form, but hopefully gather as well in the future. And thank you so much to the speakers and your time today. Wonderful to see our professional community growing in the state so we can serve our patients together. And Josh, a special thank you for your time and joining us as well.
No worries. Good to see everyone.
Thank you, Stan.
Yeah.
Bye.
Right. Bye.
Thanks.